All right, Chapter 15, Healthcare Reform and Social Policy in the United States. So the importance of access to health insurance seems to be the central question to the debate. And the importance of it can be illustrated with a few facts, or a few questions, I guess. Previously uninsured persons had worse health and used more services when they became eligible for Medicare coverage at age 65. So what they're saying is that one of the reasons why the general population, the under 65 population, having access to health insurance is that it takes some of the burden off of the government's expenditures on Medicare, which are already fairly high. Uninsured folks are more likely to hesitate before seeking treatment, even in emergencies. And both of these things taken together, what you have is a situation where people don't address health concerns when they're less expensive to deal with, i.e. at the beginning. So as a result, people either wait till they get to that 65 finish line and then see what they can get taken care of. Keep the current scheme. Or if they don't make it to 65 before having to address it, this kind of thing happens in emergency rooms, which is, again, a very expensive way to go about it. So when they were trying to craft legislation to improve the number of increase the number of people who are insured, the driving force behind it wasn't so much altruism as much as it was utilitarianism, meaning that by improving healthcare coverage in the population, you'd ultimately reduce the amount of money spent on healthcare. And why is that a big deal? Well, because the costs keep going up. Per capita health care expenditures in the United States are the highest in the world. And you can see it's kind of it's growing very quickly. In 1980, I guess it was a long time ago, it was $1,100 per person. In 2012, it was $8,900. And you keep going on. I think the newer versions of the book, you get to 2014, and it's up over $9,000. So they currently is even approaching $10,000, or even a little more now. Now, the costs are influenced by a number of factors. One is nothing we can do anything about. It's the aging of the population. And what they mean by the aging of the population is that because people are living longer, generally, and people are having fewer babies and have been having fewer babies for a long time now, what we're seeing is that if you look at the proportions of our population, a larger proportion of our population are 65 and over than has ever been the case before. And it even gets more pronounced when we start getting to the 85 and up. That's a much larger group now than it ever was before. More people are surviving well into old age. Also, you'll see increases in hospital expenses and doctors' fees. There's a lot of reasons for all that. Some of them benign, some of them less so. We have the increased cost of health insurance, which is directly tied to those first two factors. The more it costs, the more money they have to outlay for these older folks, the more hospitals charge, the more doctors charge themselves, the more the health insurance companies are going to charge. That's how it goes in a free market. Finally, we have the increased use of and advertising for prescription drugs. Now, I'm not going to get too granola here and start talking about how evil pharma or whatever, but a benign way to put this, without getting too polemic, is that all this research has gone into pharmaceuticals is resulted in some dividends. We have new drugs now that can treat a myriad of illnesses. And as a result, though, all that R&D is not free. These drugs cost money to produce, so they can charge for them. Now, of course, the prices on these drugs has a little bit more to do than just R&D and manufacturing costs. There's also advertising costs. What else is there? There's also the maxim that a drug, the cost of something is whatever people are willing to pay for it, right? So if a drug has a good chance of, say, putting cancer into remission, even if it costs only $5 to produce, you can sell that for a lot more money because, well, people don't want to have cancer, right? So again, it's a market thing. And of course, also, nobody buys these things in bulk. We're all individual customers, so we're all paying retail. Some places that have socialized systems buy these things wholesale and hence get better rates. But that's for another chapter. All I need to know now is that, yes, the prescription drugs are more plentiful and more costly than before. So, this has been an ongoing issue. During the 20th century, several U.S. presidents have attempted to, or at least recognize the need for healthcare reforms. Only Lyndon Baines Johnson's establishment of Medicare and Medicaid in 1965 was successful. The only thing that actually happened in the 20th century to address this. Now, public resistance and the opposition of the American Medical Association have hampered efforts at reform. That's why. LBJ was able to get away with it in 1965 for a variety of reasons, not least of which being he had a lot of political capital on his side, being the guy who stepped in after Kennedy was killed. And he had a Democratic Congress, and they were able to push this through. Much to the chagrin of his, the Republicans on the other side of the aisle. Now, the American Medical Association always resists reform for a variety of reasons. Most of what they're concerned about is, the financial well-being of its members. Now, the addition of Medicare and Medicaid to the Social Security Act of 1965, it marked a new level of involvement in the United States healthcare by the federal government. Prior to this, there really wasn't much in the way of assistance coming from the feds for the elderly or the poor. It was in terms of medical care, or really much else, for that matter. Medicare and Medicaid have provided needed health services for the old, those in poverty, and also the disabled, we should remember them too, where these services were not previously available. Before these programs, these people they just didn't get services. They just died. That's how it was. Harsher times back then. Now, we'll start with Medicare, not to be confused with Medicaid, which is something else. Medicare. Now, Medicare is federally administered. All right? It's entirely from the federal government, and it provides hospital and medical insurance for people age 65 or older, regardless of financial resources. So it's not a means-tested thing. Everybody gets this. Now, this also includes disabled people under the age of 65 who receive cash benefits from Social Security. So, people who are, say, have developmental delays, or folks who are schizophrenic and can't work due to either the illness or the treatment. People who are profoundly disabled, they get cash benefits from Social Security and also get Medicare. In 2006, under George W. Bush, there was prescription drug coverage was added to the Medicare offerings. Medicare Part D is what it was called. So what it did is it it greatly reduced the price of medications for people on Medicare. Now, they're not free, but they are reduced. Now, Medicare covers about 14.8% of the population. Then we get to Medicaid. Now, Medicaid's a welfare program, which is means tested. It's operated by individual states, but it gets federal funding. States and the federal government, they share the cost of the health care for the poor, so the federal government kicks in some money, the state government kicks in their money, and that's what a state's welfare system looks, or Medicaid system will look like, or at least how it's funded. Now, each state is required to cover all needy persons receiving cash assistance. Now, one thing that should be noted is cash assistance is a form of welfare is actually not as common as you would think. Cash assistance, what they call it, TANF, right? Temporary aid for needy families. It's short term. Nobody gets it for very long. It's a very kind of a short window for it. Most of the aid that needy families get comes in the form of food stamps or Section 8 housing, things of that nature. That said, if you are one of those families that does get the cash assistance, then their state is required to give you Medicaid as well. Now, Medicaid may also include the medically needy, the aged, the blind, the disabled, poor, as well as their dependent children and families. Now, taken all together, the rules from state to state do vary, but taken all together, it's 15.5% of the population. Now, if you look back, we have about 15% there, so about 30% of the population, give or take, is covered by federal or state health plans. Now, after LBJ, the next person to actually have a plan that got really any press was Bill Clinton. Not Hillary, she wasn't president. This is Bill Clinton in 1994. Now, the plan failed. due to many reasons. Books have been written about it, but these three are pretty standard and really not too argued. First is lobbying efforts on the part of the insurance companies. This national health insurance would have effectively wiped out their industry, so they weren't really too keen on this. There was a lack of consensus between the Democrats and the Republicans in Congress, go figure. And there was growing public uncertainty. Again, it was losing the war of popular opinion. It didn't get sold very well. And Americans are generally kind of spooked by the notion of socialism. Well, particularly in 1994 they were, maybe a little less now, but in 1994, absolutely. One thing it did do, though, even though it failed, it went down in flames, so one thing it did do is it highlighted the need for reform, which didn't happen under, for quite a few years later, but it did happen eventually. Other lasting effects of this Clinton healthcare reform effort was that it resulted in the reorganization of American healthcare into a delivery system in which managed care is now the dominant approach in the private sector. And what is managed care? Well, managed care started to come into its own in the early to mid 1990s, and with it, private health care shifted away from a largely office-based fee-for-service system, and that's, you graduate from medical school, you put your shingle out you've written an office space, you put your shingle out in front of it, Dr. Me, MD, you come in, we negotiate prices, right? That was the way it used to be primarily. Now, we started to see the shift in the mid-90s to a group or organization-based managed care system. Now, you'll note that what's the first question they ask you when you call for an appointment to a doctor? We'll ask you your name and such, but one of the first things they'll ask you is, what insurance do you have? Now, you could be real cynical and be like, no, they're just making sure I can pay, which I guess is part of it. But the other part of it is because our system is now a managed care system, meaning that the health plan you have determines which doctors are available to you. That's how it goes. So you have an HMO, well, there's rules for that. There's certain doctors on that plan. That's how it's all negotiated. That's how the prices are set, and so on and so forth. You have to go to that set. You have a PPO, you have a little bit more flexibility, but still, a PPO is a managed care approach as well, where a health insurer will promise to utilize certain doctors, and in exchange, they get discounts. That's how it goes. Now, this all emerged indirectly as a response to the government-imposed diagnostic-related groups, DRGs, for Medicare services. What's a DRG, you ask? Well, a DRG is a schedule of fees placing a ceiling on how much the government will pay for specific services rendered to Medicare patients by hospitals and doctors. Let's back up a step. So what happens is we have Medicare, right, which we know is about 15% of the population is covered by it. So we have these DRGs, so the prices the government's going to pay for 15% of the people getting these services, it's set in stone, right? Now, same thing, so what do you suppose Medicaid does? Well, they take those same numbers, essentially. They're like, yeah, Medicare's doing that, we'll follow the same numbers. Now you got about a third of the population almost, where any health care that's given to them is going to have price controls set by the government. And so you have that many, what you've essentially done is you've set the market. So the private insurance companies, they look at those numbers and they say, yeah, that seems good to me. That's what we'll pay as well. So that's what they'll pay the providers. So what ends up happening is you have this price sets for these different managed care groups, and it's all a way of controlling costs, right? Which again, as we noted in earlier slides, something has to be done about costs, and that's what these diagnostic-related groups were largely created to do, and these managed care groups are designed to do. Again, so they control the cost of healthcare by monitoring the work of doctors and hospitals, limiting visits to specialists within a particular managed care network, and to all physicians outside it, and requiring prior authorization for hospitalization. All of these things are meant to rein in costs. Now, what's the other side of reining in medical costs, though? Well, what you'll see is that what it all boils down to is reduction of services. If you want to keep costs down, you have to reduce the amount of services being offered. Now, what does that sound like? It sounds like a recipe for political disaster, and sure enough, it was. All right, now, part of how managed care works, I should probably talk about capitation fees before I move on. Capitation fees is a financing system employed by managed care organizations, where a fixed monthly sum is paid by the subscriber. That'd be you. Say you have your Humana HMO or whatever. That you pay your monthly sum to Humana. Your employer kicks in another chunk of money, and it guarantees that person and your immediate family, if you have the family plan, will get care for little or no additional cost. That's the idea. And what it was designed to do, capitation fees, was designed to discourage inefficient and unnecessary treatment. That's the idea. And initially, when they did this, it did help keep rising costs in check. Now, a funny thing happened, though. You started to see pressure by physicians, the media, politicians, and patients to dilute these cost controls. People started getting angry that their insurance companies were dictating what services they could get. They felt that there should be something between the patient and the doctor. There's especially a big blowback about this requirement to obtain approval from a primary care physician before seeing a specialist in many of these managed care programs, especially HMOs. And so what we have here is, we have a scenario where costs are rising quickly. And the only way that they can really think to cap these costs is to kind of come up with a payment schedule and to limit the amount of services people get. You can't just go walk into the hospital and say, I demand a PET scan. It doesn't work that way, right? You need to have some kind of reason for it. You have to go to a primary who will send you to a specialist who then will either recommend or won't recommend the procedure. It is all closely monitored by the managed care group that's paying for all of this. Now, of course, people pushed back. People don't like to have, how do they put it, bean counters determining their health care. So again, the sword has two edges. Now, state efforts, get away from the federal efforts, we have state efforts to deal with this healthcare issue. We have Hawaii, who all the way back in 1974 required all employers to contribute to health insurance for their employees. That was their way of making sure people were covered. And again, the reason why these folks want their populations covered with health insurance isn't so much out of the goodness of their hearts. Again, the view is that a population that has health coverage is more likely to get preventative care or to deal with medical issues early, both of which will, over the lifetime of the individual, result in less medical expenditure. Then, Tennessee converted Medicaid into the TennCare managed care program. Vermont, Illinois, Washington all provide health care for children with subsidies for the premiums. Then you finally have Massachusetts, which under Mitt Romney, when he was the governor, you guys remember Mittens, he ran for president, didn't win. But he had a thing, Romney Care, in Massachusetts, which required all residents to have health insurance. Sound familiar? You get fined if you didn't have it. Yeah, should sound familiar because we have the Affordable Care Act, which had many of the same characteristics as Romney Care in Massachusetts. Barack Obama put healthcare reform at the top of the domestic agenda, ran on it twice, got elected twice, and attempted to, did actually get this act passed. Now, the people opposed to the ACA were concerned about how much it would cost, increases in taxes, cuts in Medicare benefits ultimately to help pay for all this, and expanded federal funding for abortion services. That became an issue as well during all this debate. Finally, government-controlled healthcare delivery they were concerned would be too bureaucratic and unresponsive to individual needs. So those were the arguments against it. Or at least those were the concerns. Now, there were several legal challenges to the ACA about religious exemptions, the mandate for employers to provide health insurance, the legalities of paying subsidies, giving tax credits to low and middle income Americans, how those shook out. The religious exemptions were very narrow. There were still some that were allowed, but not very many. The employer mandate was upheld as constitutional, so was the legality of paying subsidies. That got close, but it was still upheld by the Supreme Court. The giving tax credits to low and middle income Americans. Again, that was upheld by the courts as well. Now, the problem of equity in health services lessened with healthcare reform, but still remains a problem in American society to this day. This is especially true for individuals dependent on public health care or those without health insurance, and both the urban and rural poor, since health care may simply not be available where they live. Now, a major factor in obtaining adequate medical care is geographic in nature. The numerical shortage of physicians serving patients in rural areas and urban slums is one of the main reasons for a lack of health care for those folks. There's many reasons for it. The first one is most physicians prefer to practice in urbanized settings. These folks didn't go to medical school all these years to go live out in the countryside somewhere. And people who live out in the countryside, they like it, but if that's not where you're from, you yearn for it, you're not going to work to go there. So they don't want to. They want to go to a city. It's they want to spend their money on fun things, I suppose. Also, 1 out of every 20 counties in the United States lacks physicians, partly because of this. There's many counties in the United States which are completely rural. Now, some folks like it, but apparently most people who come out of medical school don't. More than half of all counties, this one kind of shocked me, these counties do not have a pediatrician. So if you have kids, you have to take them to the next county over. This is one of the reasons why many children don't get the medical care growing up that they really should. And there are a few signs that this distribution of physicians is beginning to improve. Again, there's no way to really mandate this. You can't force people to live, anywhere other than where they want to live. You can incentivize maybe moving to a rural community, but to this date, nobody really has. Now, another factor in the maldistribution of physicians is that of overspecialization. This has reduced the number of doctors engaged as general practitioners in primary care and family practice. And this happens for several reasons. The medical students, if you talk to them, they'll tell you they would rather be a specialist because, number one, a specialist can focus on a narrower and more manageable body of knowledge. A general practitioner has to know, everything. That's a lot. Probably a bigger factor, though, is that being a specialist is more prestigious and you make more money. So if you're going to spend the money and effort to go to medical school, why wouldn't you want to take the more prestigious, well-paying job? I mean, some folks have, some kind of moral imperative that moves them in another direction, but the majority of folks who are going to make this kind of investment are going to want to get the maximum return for their investment, i.e., as much money and prestige as they can get. So, the existing healthcare delivery system in the United States is a conglomerate of health practitioners, agencies, organizations, all of which operate more or less independently, which is kind of a nice way of saying we don't really have a healthcare delivery system. We have a bunch of actors and people who all kind of work to deliver healthcare somehow, right? The greatest portion of all patient services is provided in offices and clinics by physicians who sell their services on a fee-for-service or per capita fee basis in a managed care network. So almost all of the physicians, there's very few physicians that don't take insurance, right? And no, we don't take insurance, you just got to pay me, right? There's not too many of them out there. There are some, but there's not too many out there. Most of them are in a managed care network, either an HMO or a PPO. And that's how it goes. The next largest portion of patient services comes from hospitals. Now, we also have official agencies, which we shouldn't overlook. These are public organizations supported by tax funds. They support and conduct research, develop educational materials, protect the nation's health, provide services designed to minimize public health problems. You have the CDC, the NIH, people like this. Then you have your voluntary agencies like your St. Jude's of the world, which are charitable organizations who solicit funds from the general public and use them to support medical research and to provide services for disease victims. I'm trying to think, the Muscular Dystrophy Association, St. Jude. I'm sure there's many others I'm just not thinking of right now. All the ones that have like the donation drives. So then we get to health maintenance organizations, HMOs, which many of you may actually be in right now, or at least your parents are, and you are as well. This is a managed care prepaid group practices. Again, this is where the individual pays a monthly premium for comprehensive health care services. And others have PPOs, a little more expensive if you look at your health plans. It's a relatively new form of managed care, of a managed care health organization. This is where employers who purchase group insurance agree, again, to send their employees to particular hospitals or doctors in return for discounts. What else do we have here? Oh, yes, the Allied Health Enterprises. These are your manufacturers of pharmaceuticals, medical supplies, and equipment. And make no mistake about it, they play a major role in research, development, and distribution of medical goods. You don't necessarily see these folks, but they are a very big part of the healthcare industry. Traditional fee-for-service system is modeled on the principle of the open market. High-quality services and affordable prices are supposed to result from competition among providers. So the idea is that you have many doctors in an area, they'll compete, and that is what will keep prices down. The same way, when you have 3 gas stations on one corner, those gas prices all kind of trickle down to whatever the lowest one is, right? So if somebody goes down 2 cents, everybody else goes down 2 cents to be able to compete. That's the idea for the traditional fee-for-service system for physicians. However, this system is not a good example of a competitive marketplace. The fundamental law states that when the supply of a product exceeds the demand, prices should drop. But the problem is that this does not apply to medicine, since doctors and hospitals effectively create their own demand and provide services at prices that they set. So it doesn't really fit the free market model really well. And this is why those medical costs keep skyrocketing every year. It doesn't fit the free market model very well. The free market model would, in fact, would result in some kind of price controls. I mean, if you look at what gas costs or heavy price televisions lately, the prices come down because they're all in competition with each other. That's the genius of it, right? But healthcare services aren't really quite fit. They're not the same. And that's why it doesn't really work. Now, to get into the debates about all of this, I'm not going to take too big of a position here, but I will note that how you feel about healthcare reform all boils down to, largely, whether or not you view healthcare as a right or as a privilege. Now, we go through our sociological perspective, see if we can get a little bit of insight here. Conflict theory. Again, this is the sociological perspective which takes the position that the social inequality leads to conflict, which leads to change. This comes from the work of Karl Marx and actually another guy named Max Weber, who you probably haven't heard of. You've probably heard of Marx, maybe not so much Weber. The modern focus is not just on class conflict, like Marx would have had, but also on competition between interest groups, as they maneuver for advantages in democratic political systems. So, modern societies, continuing on, are characterized by conflict between democratic principles, which emphasize equality and universal rights, and the organization of economic services, which involve the production, exchange, and consumption of goods and services, which features inequalities built into it. So we have a natural conflict between democratic principles and the economic system in which we live in. This isn't new. This is the way it's always been. And it's always been the degree of alacrity with which we actually deal with this conflict that has always determined whether or not we've been successful as a nation. Now, health reform, like I said before, is really about whether or not you think it's a right or a privilege. And as a privilege, you view medical care as a commodity. Really no different than food or gas or even housing or TVs or whatever. Doctors, you would argue, are entitled to high incomes because of difficulty of becoming a doctor and the high value placed on obtaining the necessary skills. It's what's called the Davis and Moore hypothesis, which is just that if there's a skill set that's out there that's much more rare, it should be paid more. And something that's much more common should be paid less. If we don't pay more, we won't have enough people trying to become it. Right? This is all part of the healthcare as a privilege kind of idea. It's more of what you call a functionalist approach. Now, what do we have? Those who view healthcare as a privilege also are more likely to have this generalized opposition to the welfare state. And they would argue that the best way to help the poor is to provide them with jobs so that they can buy medical care just like everybody else. Now, the as a right camp, they would argue that healthcare should be an opportunity. It emphasizes its special importance to society in relieving suffering, preventing premature death, and restoring the ability to function to people who live in it. So, the as a right camp don't view healthcare as a commodity. It's viewed as something else entirely. It should be removed from the markets. It shouldn't be treated that way. It should be treated as a chance to improve our, not just the well-being, but also the productivity, really even, of our society. Finally, the Healthcare as a Right group would argue that society has an ethical obligation to provide healthcare, that it's unethical to allow people to die because they don't have the money to attain healthcare services. Now we see a movement toward conceptualizing and establishing healthcare as a right in the capitalist economy of the United States. It's been the trend up until a little bit recently with the more recent administration. Now, this is consistent with other measures associated with being what you call a welfare state. This welfare state it's a little politically charged here in America, but all it means is a country that has social safety nets like Social Security, Medicare, Medicaid, healthcare, that kind of stuff. Western Europe, the whole lot of it would be considered welfare states. Not welfare in the sense of TANF for food stamps, but welfare, general welfare. All right, don't want to belabor that too much, but there is a semantic thing there that sometimes trips people up. Now they would argue, the movement that we're seeing now is that individual rights of citizenship. By virtue of being a citizen of a country, you get certain rights, not because of ownership and control of property. So it's citizenship, not control and ownership of property, that serves as the basis for political representation and entitlement to public programs.